Okay, so it is 2:05. Thank you for joining Dr. McConnell. And I think we'll get started with the introductory slides. So thank you all for joining our research seminar on impacts of air pollution on metabolic health outcomes for California residents, contract 22 RD010. So some logistics notices. The seminar is being recorded and it will also be uploaded to the CARB YouTube channel after. So if anybody, I guess, can't be here for the full time or they have anybody else that was interested in joining but couldn't make it today, please check that out later. All of our attendees will be muted during the presentation, and we will have a Q&A session that begins after the presentation. Please type your questions or comments in the chat box or use the raise hand function, and you will be able to unmute and ask your question. We do have a project webpage for the research project, which will soon be uploading our final report, the seminar presentation slides, and the seminar recording will be available on the YouTube channel, like I stated before. For any questions or comments after the seminar, please contact Eric Ramsey, which is me, at my email for CARB. And let me also provide the link in case the QR code isn't working for folks, and that is my email. So firstly, I'll introduce some of our speakers for today. This is Dr. Jason Su from UC Berkeley. He is the PI of this project. He's a researcher at the School of Public Health at UCB with environmental health sciences. Dr. Su has a background in geographic information sciences, remote sensing, and Microsoft certified application development. This has allowed him to build a strong foundation on application of information technology for large-scale data processing and statistical analysis. With his postdoctoral research experiences in environmental epidemiology, he advanced his career to machine learning modeling and biostatistics analysis. Additionally, he has developed skills in applying mathematical and machine learning algorithms for environmental exposure, modeling, and assessment. And this is our other speaker, Dr. Sadir Al-Kindi. He's a clinician investigator at the Houston Methodist with experience in cardiometabolic health, air pollution, and neighborhood health effects. Dr. Al-Kindi's research has focused on non-traditional risk factors for cardiometabolic disease, with a focus on environmental exposures. His recent research focus has been on the impact of air pollution on cardiovascular risk, and he has published over 250 manuscripts on cardiometabolic health and large population-based studies, and participated in multiple mechanistic trials studying cardiometabolic diseases. He's also worked with large patient registries such as the SPRINT trial and Network for Organ Sharing to understand the relationship between pre-existing traditional risk factors, air pollution, and cardiometabolic risk. And our third speaker is Dr. Timothy Brown, also from UC Berkeley. He's an associate professor of health economics in the Division of Health Policy and Management at the School of Public Health at UCB. He also serves as associate director for research of the Berkeley Center for Health Technology. He's a health economist who teaches econometrics and health economics at the graduate level, including cost effectiveness analysis. Additionally, he has published the first set of studies that rigorously estimate the return on investment for public health systems in California. His work focused on determining the causal relationship between public health expenses, health status, and mortality, in addition to rigorous health status valuation. So this is a brief overview of the research project. This research has shown that both short-term and long-term air pollution raises metabolic health risk. For example, type 2 diabetes, diabetes-related hospitalizations, emergency department visits, medication use, etc. But most research focuses on urban areas with coarse, dusty air pollution or looks at long-term single pollutant exposures. The main goals of this research project was to develop health estimate models for multiple health pollutants, including PM2.5, NO2, and O3, and exploratory health models for toxics, including benzene, chromium, nickel for metabolic health outcomes using pre-developed exposure model results, and to estimate statewide and per capita avoidable medical expenses and value of overall avoidable loss of life for metabolic health outcomes. And this is a brief seminar agenda. So firstly, Dr. Jason Su, the PI, will be introducing the project today. Then we'll go into a literary analysis of air pollution and diabetes by Dr. Alkindi. Then it will go back to Dr. Jason Su for exposure modeling health analyses. Then to Dr. Brown for the economic benefit analysis. And then finally, back to Dr. Su with key takeaways, conclusions, and next steps. And with this, I will pass it over to Dr. Su so he can begin his presentation.
Thank you, Erika. Do you want me to use my presentation, or could you run the presentation for us?
I think it would be more. I think it would be best if you presented, just because I know that you also probably have your own pace that you would like to present. So if you could pull those slides up, that would be really appreciated. Thank you.
Let me try. Okay. Can you see it? Okay.
We can, yeah, there you go.
Great. First, thank you for you all to attend today's final research product presentation for CARB contract 22RD010. So we have collaborators from UC Berkeley and the Dr. Alkindi from Houston, and also the UCLA Mike Jarrett, and the USC Dr. McConnell, and also Dr. John Barnes from UCSS. You also know Dr. John Barnes is also my academic advisor. Really appreciate the effort he put over here for this project, and also other things. So for this project, we have 7 tasks. So first one is literature review. Dr. Alkindi will cover that. Then I will cover task 2, basically to 5 in between. It is the development of air pollution models and the services for entire California. And we also acquire the data for the research project, then use the acquired human subjects data to identify CR functions of 5 health endpoints. Then Dr. Brown will do the health economics analysis. Then I will talk about the project management. So first, let's give this to Dr. Alkindi. Dr. Alkindi, you can take it away. But I can advance the slides for you.
Okay, thank you very much. Thank you everyone for joining. So the first task is really a literature review of the impacts of air pollutions and air toxics on metabolic health, specifically type 2 diabetes. We kind of looked into the literature, and the scope of this was primarily focused on PM2.5, which are the fine particulate matters. These are smaller than 2.5 micrometer. And then PM10, NO2, and ozone, ground level ozone. We know that these pollutants contribute to cardiometabolic morbidity. And when we talk about cardiometabolic morbidity, it's becoming more of a spectrum. We used to think of diseases as independent of each other, but now we're thinking about the disease as a spectrum from diabetes, obesity, and also chronic kidney disease and cardiovascular disease. The impact of these pollutants has been primarily through insulin resistance changes, inflammation, oxidative stress, but there are also some mechanisms which I'll talk about in a second, which focus on autonomic imbalance, endothelial dysfunction, and adverse adipose and hepatic signaling. The focus of this report, as I mentioned, is going to focus on these 4 primary pollutants, but we'll allude to some of the additional pollutants and toxics. The outcomes that we focused on are incidence of diabetes, initiation or intensification of medications for type 2 diabetes, diabetes-related emergency room visits and healthcare utilization, including hospitalizations, and mortality with or due to diabetes. People don't necessarily die from diabetes as a primary cause, but they die from complications of diabetes, including cardiovascular disease. And the goals is really to summarize the available designs, the exposure methods, alluding to some of the mechanisms that have been studied in animal and human studies, and also focus on concentration response patterns and policy implications. Next slide, please. Jason, next slide, please. Yep, thank you. So this is a recent paper that focused on understanding the exposure for air pollution, just to give you a context. And this is annual exposure. You can see that in the world, we are lucky, at least in the United States and northern Canada, and Canada and in Australia, where air pollution levels in the panel A in the left upper corner, we live at very low concentration levels relatively to the world. There's still no there's no good amount of air pollution exposure, but we live at relatively, compared with other countries, lower concentration. Where you see in other countries in South Asia, in the Middle East, and Sub-Saharan Africa, and North Africa, there is levels that are exceeding approximately tenfold what we experience in the United States on an annual exposure level. In panel B, you see that the relationship between air pollution, PM 2.5 specifically, and relative risk of incident diabetes goes up in a curvilinear fashion, meaning that there is a steep increase when we go from 0 to approximately 25 microgram per meter cube concentrations or exposures in the annual scale. And then it may plateau a little bit where we see a kind of a saturation relationship or a saturation phenomenon. This is important because in the levels, this suggests that changes in exposure, whether it's going up or down, in that low range from 0 to about 25, may have a significantly more impact compared with going from 100 to 75 or 75 to 50. And then you see that mortality from diabetes and adjusted life year in the bottom, they are significantly also different across the globe. Both are this takes into account the population size, so that's why because the U.S. has a heavy population density, relatively speaking, you start seeing it as showing up as among the highest for disability adjusted life year from type 2 diabetes related to air pollution. Next slide, please. So what are the mechanisms? If you go back one slide, yeah, thank you. What are the mechanisms? And this is a summary from published literature in across different experimental design. So this is from animal studies, cell analysis, from experimental human studies, experimental mouse and other rodent models, all the way up to population analyses. What we understand is that this is a complex figure, obviously, but the initial exposure goes through inhalation. Some of these particles do translocate to the blood and go through across the GI tract to blood barrier, and they end up in the blood. But these are mostly ultrafine particles. The fine particles mostly remain in the lung and they get embedded in the lung, and they result in a lot of different biologic intermediates or biologic signaling. These are called inflammatory signals and reactive oxidative stress. These then can start from the lung but go across the entire body, go to different organs, and it can lead to various downstream impacts that are harmful at the cell level across different organs and different cells and cell types that result eventually in chronic inflammation and low grade oxidative stress that leads to cardiometabolic disease, including type 2 diabetes. But there's also another mechanism here where it's being studied right now, where there may be a direct impact on all the olfactory nerve and the nose that basically takes some of these particles and signals to the brain directly that can lead to stress and can lead to another things, including endocrine response. So this is in the top part of the image, remains to be studied, but there are some promising studies that have focused on some of these mechanisms. Next slide, please. So everything I told you about right now, at least in the prior two slides, focused primarily on the long-term exposure. And what does the evidence suggest to us? So when we look into a systematic review of the literature, we find studies that have looked into the association between PM 2.5, fine particulate matter, and PM 10, coarse particulate matter, exposure, and incidence of type 2 diabetes. This is a relatively recent systematic review and a meta-analysis. And in the you can see that the overall effect of PM 2.5 in the top and then PM 10 in the bottom suggests that there is a significant relationship for each 10 units increase in or 10 microgram per meter cube increase in an exposure effect across average of 1 year. There is 9% increase in type 2 diabetes incidence with PM 10 and approximately 10% increase with PM 2.5. So next slide, please. So this suggests that the totality of evidence is related, showing that the long-term effects are at least associated with incidence of type 2 diabetes, and building upon the existing literature suggests that it may be actually a causal effect here. What is less studied, which is actually what Dr. Su is going to tell us more about in the analyses, is really the short-term exposure. So we know that long-term exposure is bad. The question is, are fluctuations, which can sometimes be dramatic on day-to-day scale, whether it's due to air quality measures or wildfires or other types of events, what does that have to do with incidence of diabetes? There is no study that has done this, so we started to do a systematic literature review. We focused, like I mentioned, on PM 2.5, PM 10, NO2, and ozone, ground level ozone. And we looked into the incidence of type 2 diabetes, and we looked into a variety of different studies. As usually the case in a lot of these studies, there is a lot of different heterogeneous kind of quality for the studies and so on and so forth. So we've identified initially approximately 3,000 papers, and then we screened them all the way with some specific exclusion and inclusion criteria, and we reached to approximately 77 studies that were included in the analysis. And you can see the distribution. The majority of the studies are from China, but we do have a significant amount of studies in North America, specifically Canada, but then also United States. And there are some studies in South America and in Australia, and some in Europe as well. Next slide, please. Just to give you a summary, because the studies are very heterogeneous, there is no good way to actually combine them all together because they report different methodologies and different things. But conceptually, when we start to analyze this, the key concepts is that acute increases in all of these 4 air pollutants can lead to metabolic disruption rapidly, and the effects can occur within hours to days, and the mechanisms are probably through inflammation, oxidative stress, and neurohormonal activation. This systematic review of 77 studies across 22 countries showed that the exposure windows that were studied did either the same day exposure or up to 3 to 5 days prior to. And the outcomes included hospitalizations, emergency department visits, and mortality primarily. There was no study that looked at intensifications of medications or medication initiation. The modifiers showed that there is a stronger effect in cold seasons. I think 2 studies showed cold season intensifies the relationship between air pollution and type 2 diabetes. Younger individuals in certain regions, and also if there was a wildfire exposure, all of these seem to be associated with higher susceptibility to air pollution effects. these are influenced by the temperature, comorbidities, and socioeconomic context. So the key findings that we find is that PM2.5 increases acute events between 0.5 to 3% per 10 units increase, and the strongest effects were noted at lag of 0 to 2 days prior to the event. NO2, consistent increase in hospitalizations and mortality by 2 to 7%. The units are interquartile range, so they're not comparable to the PM2.5, and PM10 is similar but has weaker effect overall. We also found that ozone has inconsistent effects. There is a couple of studies that looked at the threshold effect, so there may be a threshold effect, but the evidence is not clear. And a few studies looked at SO2, which showed mixed results, but primarily attenuated or even eliminated if you adjust for PM exposure. So the clinical implications for this is that air pollution can be an acute metabolic stressor, which can trigger hyperglycemia, insulin resistance, and diabetes-related complications. And we need to be aware as clinicians to the effects of air pollution and maybe design a specific warning systems that can be a decision support for clinicians and patients. Next slide, please. And the key knowledge gaps, our study showed that there are 6 key knowledge gaps. One is the evidence overall is outdated. It's limited, and especially in the US, it's very limited contemporary data. Wildfire exposure, it's an evolving pollutant, but has not been very well studied in this context for type 2 diabetes. The population diversity, there is underrepresentation of high-risk populations, especially kids and elderly individuals, but also marginalized communities. Short-term effects are inconsistent overall. They have not been studied and compared from one exposure to another. The exposure modeling has not been standardized, so there are different methods to do this, and it's difficult to compare and contrast. And then we also realize that there is exposome, which is the totality of exposures, multi-pollutants, and maybe other environmental exposures that have not been studied in this context. So there is a need for integrated and high-resolution diverse population studies. And hopefully this is a good segue for Dr. Su's presentation. Next slide. I think this is my last slide. Yep. Thank you. Dr. Su, if you're talking, you're muted, I think.
Okay. Sorry. Yeah, Dr. Gandhi, for pointing that out. For most of the exposure studies and the social health outcome analysis, they used coarse resolution, the exposure data. Our goal over here is we are focusing in California. We want to develop high spatial temporal resolution air pollution services. So over here, so for us, we use kind of deletion, substitution, addition algorithm as the advanced machine learning non-use regression model. So we used 3 types of data source. Because of time, I cannot go into too much detail. If any of you have interest, can contact me later. So we use one is there is a buffered impact of the 90 use, 90 cover, and also the traffic, daily traffic. So they all go from 50 meter to 5 kilometer at a 50 meter interval. So that's one kind of predictors. So also we have the non-buffered. So like the grid map. So it's the meteorological conditions. We also have 2-week vegetation index. We have the aerosol optical depth. That's mainly to identify the impact of the or the concentration level of PM2.5. So we have ozone and also NO2 from ozone monitoring instrument. So for us to get a very high spatial resolution, we also used the University of Washington random models PM2.5 as part of the predictors. And also we used the NASA's reanalysis as part of the predictors for NO2. So those are the non-buffered remote sensing data. We also used typical data, what we use for non-use regression model, that's the digital elevation model, distance to coast, distance to roadways, distance to ports, and the location category. Location category basically say, okay, which one you are, if you live very close to the highways, or that would be, we call it GMC, or you live close, not close to highway, but close to major roadways. That's another one. And the third one is you are very far away from all the major traffic sources. So these are the major components or predictors we use for model. Oops. My screen. Okay, so we built non-use regression models for the 3 criteria pollutants, NO2, PM2.5, ozone at a daily level. The models were built at a resolution of 30 meters across more than a decade. Over here for NO2, so we have the government monitors. We have the saturation monitors. Saturation monitors are the one we did collaboration with CARB from other projects. So, and also Google Streetcar monitoring. So for the Google Streetcar monitoring, they have covered from 2016 to 2019. So these are the 3 types of sources or monitors we used for NO2 as response, right, to build the models. Or we have the process of getting the data. Like you cannot use all the data like it's a Google Streetcar monitoring data. It's so dense. We use some techniques to identify some of them without any spatial coordination. So that's part of the process. Then for PM2.5, it's only the government regulatory monitoring. So for the years, from the first, I think in 1989 or something close to, or 1990, so to have around 330 PM2.5 monitors. For ozone, we have government regulatory monitors, but also the saturation monitors. So this, for the government monitors, is getting more and more during the, to the current years. For saturation monitors, the same, we got support from CARB, from other studies. So this is the summation, is a summarize of the number of monitors, unique monitors throughout California for the government monitoring size. You can see different years have different number of unique monitors, but when you add up total at the right side, at the bottom, the total number of unique monitor size for the entire California across all the sampling periods, basically from 1990 or from 1989 from ozone. So we used, as I say, we do not have enough time to deal with to talk too much. But if you do have interest, we can discuss that later. We use kind of deletion, substitution, addition, non-use regression model to model the impact of non-use, non-cover, the traffic, and also those remote sensing data, and plus the typical fixed predictors, we say, on the impact of levels of concentration. So for NO2, the adjusted R square is 0.084. Shows over here for you, it's every 10 years. The first on the left is 1990, the second is 2000. The third one is 2010, and the fourth one is 2020. So this is the modeling results for NO2. As I said, we used spatial resolution of 30 meters to build a model, but to save some space, California is big, to save some space, we developed the surfaces using 100 meter spatial resolution, but still, the 100 meter is very high spatial resolution. We developed daily surfaces, basically from 1990 all the way to 2020, I would say, or 2021, we use that too. For PM2.5, R squared is 0.65. This is what we could get if I wanted to increase the adjusted R squared. I could easily add the like air basins. It can easily get me over 0.8 or something. But you also need to understand 0.65. That means it's adjusted R squared. Okay, that means the correlation is over 80. So 0.8. This PM 2.5 surfaces. The ozone modeling results, the adjusted R squared is 0.92. So this also from 1990 to 2000, 2010 and 2020. Okay, so we also developed the air toxics models and the surfaces. So this one has been going on forever almost. Before we try to develop daily, but since it's not enough information for the change, we try to develop the monthly. Still, it's not because it has some issues like the number of monitors and also the variation of the predictors. So we changed that to annual services. So we developed for 5 of them: benzene, chromium, nickel, lead, and once we put it in. So we use the same typical non-user regression models like we used before for the criteria pollutants, but we also have the emissions. CARB have the emission factors. So for the individual air toxics. Also, I use for this one remote sensing centennial multispectral imaging. They have some specific information on the combination of bands on the air tox concentrations. So that's why I used that one too. So for air toxics monitors, so throughout the history, the range from 46 to 91. The adjusted R square from 0.59 to 0.81. I know the unique number size is a little bit low, but that doesn't mean you cannot detect any the spatial gradients or spatial gradients of concentrations for the air toxics. So we know we want to understand, or if possible, to know the NIST exposure misclassification, but also we wanted to know the comparison of the gradients of the concentrations, the difference of the concentrations throughout space. That's our goal. So so for the air toxics, this are the 5 that want to. So this through entire California. Benzene has some impact, a lot of impact also from traffic, also nickel. The other ones that do not have specific traffic impact, but the chromium has regional impact. But these are the air toxic surfaces. Okay, once we finish the development of the pollution models and the surfaces, and then we wanted to acquire data. So over here, because the air pollution surfaces, air pollution models and surfaces are through for entire California. For the house outcome data we acquired also go through the entire California. So we go through the not like most of the studies, they used proportion of the regions of the subjects. We went through all the available data. So like the CHIS data is California House Interview Survey data. This is provided by UCLA Center for Health Policy Research. So they include incidence of diabetes or diabetes medication use. We do not have own those data, but we run the simulation codes based on the structure provided by UCLA. Then once we tested our code and we send the code back to UCLA and they run the codes and also send us the results. For the diabetes, ED visits, and hospitalizations, those are from HCAI data, or you can say the HPD data. Those are also population level, or population for those with diabetes. And also we also acquired the mortality data and related to diabetes from California Department of Public Health. Those are also statewide data for every single person with diabetes-related mortality. So those are the three type of systems of the data. But when we apply IRB, so we basically needed to apply agreement and data access for each individual department of the state, and also at the same time apply for approval from the state CPHS. And once we get that done, then we go through the once the state approved our application, we get the agreement to to the UC Berkeley. So UC Berkeley will apply IRB reliance. In that way, we get all the agreements done and get the data. Okay, those are how the data were acquired. So now we talk about the CR functions. So we have 5 health endpoints over here. One is the incidence of diabetes. The second one is diabetes-related medication use. So from CHIS annual data. And the second, the third one is the ED visits. The fourth one is hospitalizations from the hospital data. And the fifth health endpoints is the mortality data, mortality from the CDPH data. Okay, for CHIS data, so CHIS data, the survey data, right? The annual. So what we did for the incidence of diabetes, so we used conditional logistic regression with exposure lag from current year to last 3 years. We used controls. So for each case, we use control is through the diagnosed year, the same diagnosed year, the same diagnosed age, the same sex, and the same race ethnicity. But you can see, even though I think the CHIS survey data starts from 2011, but because you can see over here, it have diagnosed year might come from far earlier than 2011. So that's why when you see the results, it have show from 1990, those kinds of things. But also for the control population, not necessarily be type 2 diabetes. As long as they have the same year and it's the same age, the same year, that means, okay, that will be the same year, that means it's the same age. Okay, so that means the age will be same, sex will be the same, and the race ethnicity will be the same. The confining control, they include age, sex, race, smoking, whether or not a current smoker, and BMI, and whether or not English speaker, and also the house insurance. You can see we even though in the selection control we used the age, sex to match, right, race, ethnicity, but when you pull all the data together, the have those people with different information on those, so we included them in the model too. So that's the type 2 diabetes. Type 2 diabetes medication use it also is conditional logistic regression with exposure lag from current to last 3 years. So so the confining control, we used the age, sex, race, ethnicity, smoking status, and BMI, English language speaker or not, and also health insurance. So for just have another information over here, but you can see, okay, since all years, that one is in kind of like a pink. So it shows NO2 is significantly associated with overall diabetes incidence, right? And for other ones, they're also largely positive, but some of them are not statistically significant. It has gradually goes up to current years period. But also exposure lag from 0 to 3 years, when you compare them, they do not show significant difference. So this is the NO2 impact or association with diabetes incidence. PM 2.5, since impact or associations are higher than NO2, and also more of them are significant. And the same trend is that once you get closer to current years, the effect is higher. But the same similar exposure lags from 0 to 3 years that do not change significantly between them. O3 seems a little bit less significant when you go to different periods compared to NO2 and PM 2.5. But the overall all years, the one with pink ones, that they are significant for lag days, lag years 0 to 3. They're still largely positively associated, but some of them are not statistically significant. Okay, now for those are for criteria pollutants. Now for air toxics, I'm showing you 5. This one shows 2. The left side one is benzene, the right side one is nickel. Okay, for benzene and also the nickel, all years they are statistically significant with pink ones, right? They're also like the same thing as similar to criteria pollutants. So when getting closer to current years, or getting close to our time periods, our current date, and then the effect increase. This is for benzene and nickel, and also for the other 3, they're also significant. Most of them positively associated with the diabetes incidence. Effects are similar when you go to the current years periods. The effects are a little bit higher, and also the lagged effects do not seem differ too much from 0 to 3 years. Okay, those are for incidence. Now we're talking about medication use. Medication use is insulin or pills usage. You can see for criteria pollutants, PM 2.5 has the highest impact. Then come to ozone and NO2, but they're all statistically significant for different legal years. Okay, for medication use, air toxics, they're also significant. Since with nickel have the highest impact, kind of chromium have lower, but they're all statistically significant throughout all the likely years. Okay, that's the first one used for us that used CHIS data. CHIS data is survey data. It's to try to be population representative, right? But the survey data is across California. We used basically from the first, what the height to all the way to the current. So that's the GIST data. Now we are talking about the hospital data on ED visits and hospitalization for impact of the criteria pollutants and air toxics. Okay, for hospital data, we have data. Well, over here, we use individual level data. We acquired the data at the individual level. So you have ED visits, which day you have ED visits, and then also you have the hospitalizations. We use that as a binary outcome. We use the conditional logistic regression through case crossover design. That means, okay, assume I have ED visits today. I went to the hospital to treat my gout. I still have gout to be honest. Then I will compare that to 1 week before or myself when I do not have gout, and then 2 weeks or 3 weeks or 4 weeks ago. So those are called case crossover. So you can control a lot of variables that for myself I do not change, right? But still, when I go back to 1 week, 2 weeks, 3 weeks, or 4 weeks ago, I still have the impact of meteorological conditions. The environment changed too. So like rain, temperature, relative humidity, we still control that. But I'll go over here is that we assume the current day when I had ED visits or hospitalizations, that day is due to me for having higher air pollution compared to control days. That's why I have the ED visits or hospitalization. So that's a modeling technique for data of emission on ED or hospitalization. For hospital length of stay, it's a continuous outcome. We use a generalized linear model with Poisson link. So confining, we used age, payer type. So it's basically the insurance. Race, ethnicity, care type, and a primary language, and then also the meteorological conditions associated with people. These are all at individual days for individual person, but it's the entire California population. So for NO2 ED visits overall effect, then you can see over here I said overall effect. These are the data lumped together from 2010 to 2019. So the basically the significant, the NO2 is significant associated with the ED visits across all the control situations and also different lags. Lags gradually decrease a tiny bit once you go to lag 3. Some of them are not statistically significant anymore. This is consistent with Dr. Arkindy's observations through literature review. It's basically 0 to 2 days are significant, the most associated with the outcomes. So, okay, we also did sorry, it jumps. Okay, race ethnicity effect. I put one is you can see the white. Do you see the white ones? Those are very few, very short confidence interval. Those because the white population almost have the highest population, so they have smaller confidence interval level. But most of them are statistically significant, unless sometimes you go to the lag 3, some of them show not statistically significant, but majority of them, 90% of them are showed over here. They have statistically significant association with NO2 for all the race ethnicity categories. So also for the control, once you control from 1 to 1 to 4 to 1, you can see they have gradual increase when you go farther away from the the case study. Okay, for the PM 2.5, PM 2.5, okay, we removed 2 years of the data. We didn't use for NO2 because they do not have that unexpected impact of the concentration. For PM 2.5, we found 2018 is exceptional year with very high impact of wildfires. Because over here we are dealing with the statewide data. So we are not, so the basic PM 2.5 in 2018 to disrupt the entire pattern of analysis. And also in 2010, there's a very low PM 2.5 exposure, and also the ED visits, very low ED visits. So that might be the data issue itself. But once we remove those 2 years of data, we still find over here PM 2.5 are significant associated with ED visits. Okay, this similar to NO2, the effect slight increase when the control days goes farther away. Also similar, the exposure lags gradually decreased. Now when you go to race ethnicity, the patterns remained. Then all race ethnicity largely significant, except when you go to like 3 days, they might have minor some of them, but not majority of them are significant associated with PM 2.5 exposure. Okay, for O3, so this similar to what Dr. Alkindi found here. Over here, O3 ED visits, we controlled basically for NO2, PM 2.5, and also social economic status. There are largely negatively associated with ozone exposure, unless you 1-to-1. So some are positive, but none of them, since they're largely statistically not significant. Okay, that's the ED visits, right? Now we're talking about the hospitalization. So over here, still binary outcome. It's not a length of stay year. It's binary outcome. Whether or not that patient went to hospitalized for that specific day. In that way, you can see for NO2, it's largely statistically significant. And also when you go from control 1-to-1 to 4-to-1, you go farther away, the effect seems increase. Also for the likely days, it goes down slightly once you go from 0 to 3 days of lags. When we further stratify into the race ethnicity, for NO2, similar to what we had for ED visits, they're significant. Okay, for PM 2.5, this effect is largely significant. And also once you go from control days to 1 to 4, the further away, the same thing, further away, you have greater impact. And also the like days, once you go further away, you have smaller effect. So 0 to 2, mostly the higher ones. Okay, and also the hospitalization race ethnicity stratification. So it's similar to what we have done for NO2. Okay, ozone hospitalization overall effect. We've also controlled for NO2, PM 2.5, and the social economic status. Hospitalizations showed positive, right? But still, they're not statistically significant. Most of them, it's an improvement compared to O3 related ED visits, because most of O3 related ED visits are negative. So this is a positive for hospitalizations. So other things is similar. Race ethnicity. Yeah, we find some of the positive associations once you go to O3 hospitalization, but still a lot of them are positive, but not statistically significant. Okay, now we talk about ED visits, hospitalizations. Hospitalizations is binary outcome. Now we talk about hospitalization length of stay. Over here, so NO2 effects are significant for all the legs, right? But once you go leg goes further away, it goes down a little bit. We'll have now going down, drill down to race ethnicity. Most of them are significant, positive, except for Asians. Asians is kind of bizarre. For like 0, it's a positive, but not statistically significant. And Asian goes to for like 3, it's basically a negative. Oh, that was NO2. Now we'll talk about PM2.5. PM2.5 similar is to NO2. So there are significant associated with length of the PM2.5 impact. When you go further next, the effect goes smaller. When you go further drill down to race ethnicity, they're largely significant associated. So over here, the change is kind of black population of the when you go to like 2 or like 3, they get significant, but when you go like 0 and like 1, the negatively associated. Okay, for ozone length of stay, we controlled it for NO2, PM2.5, and social economic status. Only like 0 is significant, positive. But when you go like 1, 2, and 3, it goes opposite. Okay, you go down, drill down to race ethnicity. Basically, they're largely negative. But there are some of them like other race ethnicity category, or sometimes the white population, they cross the 1 point horizontal line. Okay, so this is a summary of the trace data. And also the Hakai data. So we have diabetes incidence. The PM2.5 is greater than O3, than NO2. You can see over here the range is around 0.1, is around percent, around 1% to 7%, and this effect, the size of effect, is similar to what Dr. Akimbi has presented. And the air toxics, how nickel goes highest, and it goes down chromium smaller, but still significant. All our research findings find that effects for instance, the later years or years closer to current period have greater effect. Exposure lags do not change much. That's for incidence. For medication use, similar to incidence, PM 2.5 is the greatest, and also air toxics. So nickel goes highest, similar to the incidence, and also way goes to chromium. But so the slight increase in exposure lags, but not significant. Basically, for incidence and medication use, exposure lags do not change much. The annual data, what I want to say. Okay, for the ED visits, use hospital data. The NO2 effect is greatest. The PM2.5, the ozone overall has positive but not statistically significant. NO2, when you go back to those figures, have a higher impact in Hispanics. PM2.5 have greater impact in Asians, Hispanics, and the West. When you have longer control windows from 1 to 4, you can see that farther away control windows have higher effect, and lags typically reduce. You from 0 to 3 days, they typically reduce. For hospitalizations, okay, over here, hospitalization is binary outcome, right? So NO2 and PM 2.5 were similar to ED visits, but O3 is elevated. But compared to ED visits, O3 have higher impact, but it's still statistically not significant. Race ethnicity impact is similar to ED visits for hospitalizations, except ozone, and also similar to ED visits, hospitalizations also have an effect. Is when you are more farther away from the control days, you have greater, farther away from the case days, you have greater impact. And when the lags goes further, effect is smaller. When you do length of stay using hospital data, hospitalization, NO2 PM2.5 are statistically significant, including the race ethnicity effects. Ozone has some elevated impact. Some of the significant, like the one is only in like 0. So the largely they're not statistically significant. So this is a summary of trees and hospital data. Okay, so now we talk about 1, 2, 3, 4. This is the 5th health endpoints. It's mortality data. So for the mortality data, what we acquired is from CDPH mortality data, right? But mortality data is mortality. All people died. So for each person died due to some are primary or some are secondary, died have some relationship with type 2 diabetes, and then we use 1 year exposure before the death. So that's the exposure. But when we go to the control, even though all people died, but some people died at the time of some people died, there are still in those mortality data at that time, those people are not dead, not dead yet, right? So, so we each death, we matched 1 to 2 controls. We based on the month, year of birth, race ethnicity, but those selection of controls are not restricted to type 2 diabetes patients or with diabetes type 2 conditions. We have confining control is age, sex, education, and race ethnicity. So our research basically found the NO2 has significant impact. And also PM2.5 has significant impact too. But also the positive. So this the main effect impact NO2 and PM2.5 on mortality. Again, this for all the data, what we have done, we will try to reduce misclassification in both ends. One is the exposure. We try to develop very high spatial temporal surfaces. For I know for the air toxics, so I knew, but for the criteria pollutants, so daily covers the entire study period at a very high spatial resolution, 100 meter. And for the health outcome data, we do not use the regions like San Francisco Bay or SoCal or Central Valley. We use statewide data, so it's population level data, even though the trace data might try to be population representative, but there's still survey data. For all our efforts, we try to reduce misclassification from exposure and also from health outcome side. Okay, the overall conclusion is the PM2.5 has the strongest and most consistent association with incidence, medication use, ED visits, hospitalization, binary, and also hospitalization length of stay, and plus mortality. NO2 have similar effect, but sometimes smaller. Ozone associations are weaker. Some of them show elevated effect, but some of them showed negative impact, but most of them are statistically non-significant. Effects tend to stronger when you go shorter like days or shorter like years for trace data. Air toxics have significant impact, or you can say the association with incidence and the medication use for diabetes related patients. So overall, our evidence supports significant adverse impacts of air pollution, including criteria pollutants and air toxics, and the type 2 diabetes burdens. Okay, we have some limitations, even though we are using statewide data, population data, but also the high spatial temporal resolution. We still have some limitations that we could not rule out some residual confining. For exposure misclassification, we could not measure where people move. Like what I have done with Propeller House and also funded by CARB, that we use the rescue medication the people use asthma rescue sensors to track where people are. So those might be better to know the people's movement spatial patterns. We do not have behavior, occupational, or clinical health factors. Some subgroups maybe have a smaller sample size. This is especially true for mortality. For ED visits, hospitalizations, those race ethnicity subgroups are not an issue, but for mortality, because people don't die twice or die easily, so typically, unless we also exclude the accidental deaths when you do the mortality. So the death population, when you go to subsamples, like race ethnicity, you might have some issues. Temporal trends, those are the ones is out of control. It's very hard for us to identify or disaggregate those impacts. For sure, this one, what I presented to you, only used overall. You can see a lot of subtitles. I said overall. We did have temporal trends analysis. We actually analyzed yearly. For the results showed you, we also have each year by year, as long as the sample sizes are big enough, for individual hospitalizations, those are enough. But for mortality, that's much harder. So that's what we have done for the exposure modeling and the impact of criteria pollutants and air toxics on 5 health endpoints. Now I'm passing the slides to Dr. Brown. He's going to present the impact of those estimates from his health economics point. Dr. Brown.
Thank you, Dr. Su. Hi, everyone. I'm Tim Brown, and just to remind you, I'm a health economist, and I'm on faculty at the School of Public Health at UC Berkeley. So I'm going to be talking about the economic benefits to reduced air pollution exposure, and I'm focusing primarily on healthcare costs. So years ago, I was at a conference explaining how much value that we could save by public health expenditures, and I was valuing life, and I was valuing improved health. And they said, what about real money? So here we're talking about real money. So this is healthcare costs. And then we'll also be talking about what I think is actually very important, the value of reductions in mortality in terms of the value of a statistical life. Next slide, please. So the data on costs comes from multiple sources. So this is a project that was done, and this is national data. So let me back up. So all of the information I'm going to present is economic data that's overlaid all of the models that Dr. Su presented in the previous presentation. So this is a very sophisticated set of cost data. So we have data from Medicaid, from Medicare, that's inclusive of Medicare Advantage. This includes commercial claims from a number of different sources. We have hospital administrative data from the federal government, from the Agency for Healthcare Research and Quality's Healthcare Utilization Project, HCUP. And then we have household survey data from the Medical Expenditure Panel Survey. This is all very rigorously collected data, and all of the figures that I'm going to present are age and sex standardized, and they're all adjusted for inflation. So everything is in constant 2024 dollars. Now, unfortunately, these cost data aren't available by race and ethnicity. This is a difficult area. I have other involves data, names and where people live in the claims data, but we weren't able to do that here. Next slide. Go up one more back. Okay, so how we're doing this is we're calculating the potential impact fraction based on the estimated odds ratios. So these are the odds ratios that were produced in the previous set of slides that Dr. Shu presented. And then we apply this to the appropriate cost category, depending on which one we're talking about. And then for mortality, we are using CARB's value of a statistical life, which was pretty close to the previous federal government, about $14.5 million per statistical life and $24. Next slide, please. So in terms of the total medical costs across all categories, so this is inclusive of inpatient, it's inclusive of outpatient. So inpatient would also include, also have ER visits in there. We have medication, we have nursing home, home health, everything. So this is including costs beyond some of the things that some of the categories that Dr. Su presented. And overall, the NO2, we have about $245 million. And this is all associated per unit increase in each pollutant. About $245.3 million for NO2, PM 2.5, about $1.24 billion, and for O3, about $1.2 billion. And I have the confidence intervals listed there. Those are calculated via an adjusted version of a delta method. So again, the unit reduction, go back please, one slide. The unit reduction here is depending on how the pollutant is measured. So parts per billion, or it could be the other approach. Next slide. That's all categories. Okay, so in terms of just medication costs per unit increase in each pollutant, for NO2, it's about $85 million. For PM 2.5, much larger at $315.2 million, and O3 less at $15.8 million. You see the confidence intervals there. Now, again, this is from the CHIS data. So this is measured in terms of the unit reductions in the pollutant. So it's the actual measure of each pollutant. Next slide. In terms of emergency department visit costs, this is measured somewhat differently. This is measured in terms of interquartile reductions of each pollutant. So that's why these numbers look smaller. So that these are different units. The NO2 is about 2.1 million dollars. For PM 2.5, just under $2 million. And for O3, almost $1 million, so $0.7 million. And then for inpatient costs, these are also measured, go forward, inpatient costs now. Great, thank you. These are, again, interquartile reductions in each pollutant. For NO2, it's about $86.1 million. For PM 2.5, almost $70 million. And for O3, almost $13 million, 12.8. And then all of the confidence intervals are shown there. In the main report, we also have this at a per capita level as well. All right, next slide. So in terms of the value of the statistical life, again, these are based on per interquartile changes. For NO2, it's about $10.4 million. And for PM 2.5, it's about $41.4 million. And then again, the confidence intervals there. We don't have this for O3 per Dr. Su's analysis. Next slide. All right, that's it. I'm happy to take any questions.
Thank you so much for your presentation, Dr. Su, Dr. Alkindi, Dr. Brown. I do see one question in our Q&A, and I see that some questions have already been addressed in the chat by Dr. Alkindi, so I'll just start with the question. It says, how does this compare with standards for PM 2.5, etc., from Charles McCaw? I believe they're referring to Jason's section. If possible, maybe if Jason would like to address this question, and maybe we could ask Charles to maybe pinpoint which specific. Oh, I see it. Another. Oh, there we go. Okay. I will allow Charles to unmute to ask a question.
Hello, can you hear me?
Yes.
Good. I have a sketchy connection, so let's hope it holds out. Yeah, thanks for the presentation, but I was left a little confused, so I have several questions. But specifically, the the presenter listed a certain concentration level of which that was significant, then not statistically significant, but below that level would be better than higher. I happen to know that in California, the PM 2.5 is about 9 point something micrograms per meter cubed. And that's the standard. And we have seen reduction in the levels of all these pollutants through the MATES over the past 20 years. So I'm guessing what I'm really asking is, where does your line link with where the PM 2.5 standards are? Because my understanding is, yes, lower is better, but we have made significant improvements in reducing benzene, PM 2.5, 1,3-butadiene. The metals are a problem because they seem to randomly crop up. But MATE says we're improving and we're saving a lot of lives. So how does your standards compare with the current MATE standards? And as an additional question, did you allow for the fact that it was much higher 20 years ago? So, I mean, what is the effect of the reduction in that? I mean, are we getting much better? And just finally, Mate says that indoor pollution is much, much worse than outside pollution. Did you confirm that? Did you adjust for that? And what happens if we improve outdoor pollution but leave indoor pollution? And I guess will GLP-1 solve it cheaper? Thanks.
Thank you, Charles, for your questions. First, I would say we only deal with over here ambient concentrations. But my academic advisor, John, and also, Michael Jarrett, so we'll have some thinking on that too. So once you ambient concentrations, they have some level of associations with indoor concentrations. Once ambient concentration goes down, indoor concentration could go down too, right? So that's one thing. And for this, what we did was what you see the results over here, the overall effect. So we have each year of the concentrations or exposures lumped together to model the effect. For sure, the concentrations have been going down for PM2.5 throughout the years. We actually have those individual years of study, but for the association, for sure, CARB contributed significantly on the reductions of PM2.5. And then we could compare, if you want to, the early years to the current years, right? Based on the trend, based on the CR functions, you can apply that. But we also actually did the individual years of study, but it's contributed by both factors. One is the air pollution level going down, but also the population changes. So the house, the house condition or population also changes, and also the like you can see different policies like Obamacare, right? Those adoptions, dramatically change the population, what we got from Auschwitz. So those have, some of them, those have, as you can say, is the complicated impact on the outcome. But I showed it over here. Overall, you can see we use the statewide data, health outcome data, and also the high spatial temporal resolution. We find the associations, most of them significant for NO2 and PM2.5, also have some issues. But if you really want to see, you want to get rid of all the complicated stories, like the introduce of Obamacare to increase the sample size, and all those kind of things together, you can identify the improvement of the air pollution associated with the improvement house or the reduced house economic cost due to like Dr. Brown's study.
But we're below the OHIA standard. We are at or below the statewide standard, which is the most aggressive standard in the state. We're well below, at least I think so, the EQ standard.
Dr. O'Kinley said that before. For sure, we are below the most of them, right? Below 9.5 microgram per cubic meter. Still, you can see those like highways, some of the highways like in SoCal, they are above 15. They are still have those ones, especially during the high traffic times and also the inversion periods, like in winter times, so it can be quite high. And also Dr. Kennedy said, there's no limit. You can see that what he presented over here. As a policymaker, you need to set a standard so for people to follow, right? But maybe Michael Jarrett or John Baum, so my academic advisors, they know this one situation much better than me.
John, would you like to go ahead?
Sure, I'll go first because you'll probably say something more profound.
That.
The standards, they're like magic numbers. I mean, there's evidence base behind both federal and state standards, but it's not like no health effects ever occur below these standards. We've been lowering the standards over the years as we have more and more evidence of lower exposures, lower concentrations being associated with health effects. So the fact that overall California air has gotten better, it's a good thing, but it doesn't mean that we've completely eliminated air pollution health effects. So I think it's really wrong to focus on the standards as some kind of bright line about which you don't expect health effects to occur. And I think, as Dr. El-Sadir, said, Dr. El-Kinder said, and Jason just reiterated, if you look at the PM 2.5 short-term exposure response function for mortality, this has been well studied. The steepest part of the curve, meaning the greatest effect per unit of PM 2.5, is at the lower bounds, close to zero. So that suggests that even when we're approaching the current standard, be it federal or state, for PM 2.5, that we still can get a bang for our buck in terms of health benefit. So I'm speaking as more of a policymaker than a scientist. I'll let Mike go more deeply into the science, but it's really not wise to consider the current standards as some kind of bright line below which no health effects occur. Take it away, Mike.
Yeah, I totally agree with everything you mentioned. All the evidence that we have from very low pollution areas like Canada, like Scandinavia, it shows that there's still very significant health effects on mortality and other important health outcomes that are at levels where the average, in Ottawa, Canada, is about 4.5 micrograms per cubic meter, and you still see large impacts on mortality. One thing that we could consider, I mean, I don't know if it's in the scope of this project, but it would be interesting to look at the benefits of bringing everybody down to standard from those areas that are above standard now. What would be the benefit in terms of the aggregate impact on health and the economy if we brought them to standard? And then say also on the low exposure, there are studies that I've done with Dr. Rick Burnett and others, and they show that there is this. John mentioned it, steeper curve at the bottom. It's called a supralinear curve, and that evidence is pretty strong. We aggregated and pooled over 40 different cohorts from around the world, and we do see that particularly for cardiovascular deaths. And in that instance, it's probably a lot of those are, as Dr. El-Kindi said, driven by, or a substantial proportion are driven by underlying diabetes. So, we definitely see, we could actually see bigger benefits by going even lower. So, I think the standard in California is still above what the World Health Organization recommends. It's almost double that. So, we have to take into account those very recent revisions to the WHO standards as well. But we could go, if we went down to the WHO standards, we'd be at, 5 micrograms per cubic meter. And they just did a very extensive analysis, and, they based it largely on the science. The World Health Organization, they don't have a political agenda, or maybe they do, but it's not part of their guideline development. It's based on the science, and that science said that you could still see health effects at very low levels. So they recommended these very low standards. I don't know if that answers your question, Charles, but happy to answer any others that you might have. I guess there was the indoor-outdoor. it's very uncommon for environmental epidemiological studies of ambient air pollution to include indoor concentrations. There are studies on indoor air. The difference is that outdoor air is regulated because it's considered an involuntary exposure. There are so many indoor exposures that are generated in the home from different cooking patterns, use of cosmetics and aerosols, that trying to regulate that is it's an important area for sure, but it's not something that is widely done. There are guidelines for that. Perhaps, I don't know if Pat Wong is here if he wants to talk about that. But so certainly, the indoor environments are important, but they're not typically accounted for. And one of the reasons that these models tend to work is that there's usually, for particulate matter and NO2, fairly high penetration into the homes. So in California, that's, depending on the season and the housing stock and the window opening behavior, that's between about 35 and 90%. And, many people are going to get a very large proportion of their indoor air pollution from the outdoors as a result.
Yes, what you say is true, but the standards has certain numerical values associated with it. With PM 2.5 or benzene, it's something like an increased cancer risk of 1 person per million over 30 years or 70 years, depending on how the standard was written. Yes, if you reduce that, you're going to save lives, but proportionately, how many lives are you going to save, and can your money be used elsewhere? Okay. And as you get down to smaller numbers, of course, statistically, you're going to get a larger percentage because you're dividing by smaller numbers. But the standards are there for a reason. And if you're looking to totally, reduce all mortality, I don't think it's possible. So if the standard at the current standard for benzene and for PM 2.5 is a small number, double digits, 5, 10, 15, I forget what it is, per million people, how low do you want to get it and how much money are you going to spend? Plus, I did ask about GLP. I mean, you're focusing on diabetes. We now have a great cure for diabetes, the GLP-1s. Wouldn't it be better to give them, you know, do that? And also, I question uh, I question your costs, because a lot of those costs are actually income to other people, and those people have their families, and that provides health for them. So you're looking at the GDP of the state. So yes, it would be great to reduce costs, but if that means, you know, reducing hiring people and things like that. So I guess what I'm saying is if we reduce jobs, then people can't afford medical care. So we have to be very careful that the second order and tertiary order effects don't undo what you're trying to do. Thank you. I'll shut up now and let someone else talk.
Well, Simon Kuznets won the Nobel Prize in Economics for pointing out that many changes in expenditures over time are not adding to welfare. So we don't want to have an economy where we're increasing pollution so that we increase healthcare costs and subsequently say we're getting better off, because we're not getting better off if we're making people sick from air pollution. What we want to do is ensure that we reduce the air pollution so those costs can be distributed to other socially beneficial areas like education and perhaps even healthcare. So that's really at issue here. The last thing we want to do is create a lot of pollution so that we have to react to that and spend a lot of money to defend ourselves against the cost of the pollution, and then say that we're getting better off. Now, there's a whole other debate on the gross domestic product and how that's calculated and all the things that it misses, like environmental externalities, like natural resource depletion, and the defensive expenditures of government are always counted as positives to the GDP when perhaps they shouldn't be, because they're not adding to welfare. So, I think that, and on the issue of GLP-1s, that they're not widely available, and many insurers right now are cutting back. They're making their restrictions much more stringent, and many people are getting cut off that used to be on these drugs. So it's not something that's going to be accessible, and that we could do with the data that's been generated by Tim Brown or Dr. Brown and Dr. Sue and our team. We could do a benefit cost analysis on the trade-offs between those alternatives. My guess would be that the most economically beneficial approach, we've seen this over and over again in public health, is to prevent the disease before it occurs, not to treat it with a subsequent pharmaceutical. So, I think it's possible that will significantly reduce diabetes, but people that are uninsured, people that don't have very good insurance policies, people have insurers like mine, HealthNet, that just dramatically changed access to GLP-1s, are all at risk if you rely on those pharmaceutical interventions.
So I'd say Dr. Jarrett's a pretty good economist. The the only issue I'd bring up is that the GLP-1 cost will change over time. So that's a moving target. But the rest of what you said, Dr. Jarrett, was right on the money. So
thanks, Dr. Brown.
Yeah, thank you, Mike. That was very good pinpointed response. On the level of 9.5 or like the changes over time, was that John could provide probably more answers on that. I think a part of the reason is that based on the level of technology we could have to restrict emissions. John, is that right?
I'm not entirely sure what you're asking, Jason.
Charles was saying why we use 9.5 microgram per cubic meter as a standard.
We're talking about the federal standard of 9 micrograms per meter cubed for annual PM 2.5.
Yeah.
Well, I was on the Clean Air Scientific Advisory Committee to the US EPA that came up with that recommendation to the administrator. The literature actually could support going lower than 9. That was the panel was 15 people or so, and that was the number that we could all agree on. There was consensus on that. The Trump administration is talking about going back up to 12. That's never happened before, that a standard once made stricter has been relaxed. But it's mostly based on epi studies, many epi studies around the world, but EPA has to focus on North American studies. There are many studies that show the concentration response function for PM 2.5 and mortality, justifies using 9 micrograms per meter cubed as the standard. It doesn't mean, as both Michael and I have said, that there aren't effects below that, but that's where there was consensus about what standard could be justified for federal action.
Thank you.
Just going to
It's an
jump
annual
in.
standard, just to be clear.
Yeah. This is Bonnie Holmes Jen, if I'm got my right volume on. Yeah, I'm the branch chief for the Health and Exposure branch in CARB in the research division. And I wanted to thank Dr. Sue and the whole research team for the tremendous work that they've done. I did want to say on this last discussion that CARB has strongly supported very strong health protective federal standards on PM 2.5. And we have a long record of letters that we can share with anybody supporting strong standards and supporting the need for standards even below the current level because of the health impacts in epidemiological studies around the world. But in terms of this particular study, I wanted to say how important it is to the ARB and our mission to reduce air pollution, improve public health, and to provide more information on the many health impacts of air pollution, including, as we're learning more about today, metabolic outcomes. the presenters talked about, and Dr. Al-Kindi talked about the research across the world in, I think, 22 countries, showing these outcomes from air pollution exposure and impacts on a range of metabolic outcomes. And we're so excited to have Dr. Sue and this team bring this research to California so we can better understand these outcomes and understand the strong benefits of the control programs that we are adopting in California and have adopted over years that are bringing down levels. But as you've seen from this research, even though we are having great success in bringing down PM 2.5 levels, we still are seeing health effects, and we still have more work to do. I just wanted to ask a question, appreciating all the research that's been shown today on PM 2.5, which is the pollutant in the research that you showed the strongest association with metabolic outcomes, and you talked through all the different health outcomes on incidence and medication use and ER visits and hospitalizations and mortality. And I'm wondering, for Dr. Sue and for all the researchers, if you have opinions on which of these do you think are the strongest and most robust in terms of doing health impact assessment for regulatory purposes, or would you consider them all equally robust and the evidence more equally robust for all these different outcomes? So that'd be really helpful to understand your perspectives as we interpret this research and look at implications and how we can use these findings going forward.
Thank you, Bonnie, for that question. It's very relevant. So based on what I have done, so for overall all the studies, you can see all the 5 health endpoints use almost all the data, right? But it's based on if you want it to be robust, you know how big a data set, right? So that's based on statistical point. You do not need calculate a sample size, minimum requirements, those kind of thing. For this one, for 5 health endpoints, I think the ED visits, hospitalizations, those are most robust, including the race ethnicity stratifications, because there are huge amounts of data over there. So we would never consider as the limitation of sample size for those 2 outcomes. For the mortality data, like CDPH data, that's the second robust compared to the hospital data. But for mortality data, this overall study, if you do not consider stratifications like that, but if you go to race ethnicity stratification, especially for those minority groups, so like you African American people, you are some of the 80%, 10%. Once you go to those ones, you stratify, and the effect becomes, I'm not sure, it's not fully unstable. It's kind of not that reliable anymore compared to the hospital data. So people only die once. So also those people die. The highly concentrated at the later stages for the exposure. For the third robust, I think, so like the CHIS data. CHIS data is still statewide, just started from 2011 to current. But so each year the sample, how many? Around 20, right? So you 20, they also only sample every 2 years. So you times those ones, the 5 years, so it's not that many people. But they try to be population representative, but the still sample size is a limitation. So I think that one, CHIS data might be the most limited. But we found statistically significant for most of the effects. I think what we have done the best with suggestions from John and Mike and also Rob. So all my previous collaborators, John is my current academic advisor, they have humongous help on me to do this kind of thing through reducing misclassification on both ends. One is exposure, another one is population. So that's why we have those significant effects. We have identified. Thank you. Is that good enough?
Thanks, that's helpful. And I know Mike Jarrett has his hand up.
Yeah,
I
Mike,
think Rob, I
Mike
think Rob had his hand up too at some point. I don't know if Rob had some things after Mike.
Well, I think Rob had his hand up first, so
Mm.
I'd like Dr. McConnell go ahead.
I was going to talk. I was going to ask about something else. So go ahead if you have something that's relevant to this.
Okay. Yeah. So I think, what's most remarkable about this project and the study is the huge amount of different sources of health data that Dr. Su and his team have brought together. And you've got acute, you've got chronic with the CHIS, everything from medication use to hospital admissions, ED visits, mortality. And for the most part, with a few exceptions, you see the data really lining up and supporting each other. So there's incredible consistency between those various analyses, and I think that's one of the real strengths here. So it's not which one is better; it's which one is, that as a collective, they present a very consistent picture, and the picture is very similar to what Dr. Al-Kindi has found in his extensive international literature search. So, that's one of the key components of causality that we look for. Are the results consistent with? Are they consistent with other studies? Are they consistent internally, and are they consistent among different health outcomes? So, I think that's a real strength. Definitely the HCI data has the largest sample, probably easier to detect small effects. I know it's really important to look at all these subgroup analyses, but Dr. Su's right. They get quite unstable when you get to the smaller groups. And it's really hard to know whether what you're looking at is a reliable statistical inference or just the result of chance because there isn't enough data to parse out those subgroups.
It's really helpful. Thank you so much. And Dr. Balms, I guess Dr. McConnell and Dr. Balms, and then Erica, you can pick it up again.
Sure. So I was going to ask about the air toxics, and the effect estimates for those were quite large, and I wonder is that an artifact, Jason, of the way that they were scaled? Are they comparably scaled to the criteria pollutants, or are we seeing larger effects of these, and maybe regulators should pay more attention to these?
Yeah, Rob, thank you. That's a very good question. This is all due to our communication with the UCLA Center for Health Policy Research. When we were designing the code, we didn't use the IQR. So we used the original scale. So everything is based on the original scale. Some of them you see very, very big effect, probably due to the original scale. So it's not standardized. It's whatever, per microgram per cubic meter, whatever per ppb or what. Yeah, that's the main reason for studying consistency. But for the criteria pollutants, so all standardized using the IQR. Dr. Brown, Timus Brown, also presented those results based on the unit impact or the IQR impact, what we have for those pollutants.
Specifically to Rob's question about air toxics, after many years of my banging on the table, I said this to Bonnie earlier today, the agency's finally realizing that we have to pay attention to air toxics. And there's a new focus. It's actually a priority for this next year to get our act in gear in terms of the health impacts of air toxics. It's always been something we've kind of avoided as an agency, but we're no longer avoiding it. So again, Jason's data are very provocative. I totally agree with you, Rob, that I was surprised at the strength of the associations that he found. More data will be needed to assess whether those exposure risks are as robust as they seem. But yeah, good job, Jason and team, and thank you for bringing up provocative data about air toxics.
Thank you, John, for you as my academic advisor. You are so kind, always provided suggestions whenever I need it. So that's great. And also, I'm grateful. Mike J was my previous academic advisor, but he still supports me a lot. I need technical aspects. And Rob too. I really appreciate his expertise in supporting my research also all the years.
Yeah, I was just going to suggest that, I think what Rob's bringing up is an important point, that these are sort of eye-popping in terms of the effect size when we look at the air toxics. It might be worth just going back and doing a sensitivity analysis for each air toxic and picking just one model, one lag, and then looking at what the IQR contrast is so that people could put it in context of the criteria air pollutants. Because maybe when you scale it to the IQR, it won't look as large, but it's definitely going to be a question going forward. And I think it's worth, it's not hard. You don't even have to run the models. You can just back it out of the coefficient and then change the exponentiated contrast. So I know I'm not trying to, I know we're close to conclusion on this, but it seems like that would be something that, as you go forward with papers is important. And I just would say, I'm glad that Dr. Bombs is pointing out that the Air Resources Board is, focusing more on air toxics, because one of the things we have learned from the tragic LA wildfires last year is that there are an enormous amounts of air toxics released during these wildland urban interface fires, and some of them very severe: benzene, chromium 6, and in the ensuing cleanup, we're estimating that these levels are affecting tens of millions of people. So it's important to get a better handle on the health effects that are coming from that, and I think this is a really good basis to start.
Thank you, Mike.
Rob has his hand up, so.
So I have a couple of questions. I'd like to echo the congratulations to the investigative team. Yeah, I think this is a huge amount of work, and it's really a good contribution. It's going to be a good contribution to the literature, and it is to the science. I have two questions. One is there's a lot more that could be done with this data set. And I'm sure you'll be doing additional work on it, Jason. But will this be a publicly available data set so that other investigators could work with you to do additional research? And then the second question is about, this was, we had some discussion earlier about the standard, and John pointed out that this is, it's a bright line only in regulation. But we haven't, and it's contested, it's fought about, and we've talked, we always focus on the yearly standard. And this raises the question of whether the sort of acute threshold for some of these pollutants is something that we should think more about, because these are acute effects, and as you pointed out at the beginning of your presentation, there's less known about them. So maybe it may be a rhetorical question or a question for Bonnie. is some of the implications of this that we should also think about the acute thresholds that we spend less time on.
Okay, I will answer the first one. Bonnie, you might take the second one. So, Rob, you have seen all my research have done with this one. I presented over here is only the overall effect. We still have those annual. So the same analysis applied for each year from 2010 to 2019. We have all those results, but because it's the time limit, I only present the overall effect. You can see a lot of slides say the overall effect. We still have individual years of study. So it basically shows the trend of impact. Of course, you have the air pollution, like NO2, PM2.5 decreasing, but the population, like hospital data, sometimes, okay, the starting low, but suddenly you have Obamacare coming over, your population increase double. And those kind of things have impact too. So we have those individual years of health outcome analysis, especially for the hospital data. You said that the data set available, what do you mean? I can share all the exposure services with you as long as you have your postdoc or your PhD students have space, a way for me to share the data with you. But the health outcome data, we cannot share. Those are acquired. When you have, now you can see the IRB application process. When you apply IRB with individual departments to sign agreement, and then the state CPHS then review our application to approve that based on the agreement we have with individual departments.
Yes.
Then with the after that, UC Berkeley apply reliance to that data. Then after that, we still need a promise. Once the contract is done, I think this one is, I'm not sure, maybe Erika can know, is April 15 or something. We need to destroy the data after that. So we cannot host the data anymore. But if you want it, you have your other thoughts. I can provide how we acquired the data the health outcome data. But if you want to exposure side data, just let me know. Not you students. No, and I can get them to you. Bonnie.
Yeah, and I just I think you were asking about the short-term acute effects and kind of the focus of our research, if I have that correct. And we do have studies, including on wildfire smoke, something that Dr. Jarrett brought up, looking at short-term effects. But I appreciate your suggestion. We're, as you know, we're developing our research projects every year, and I appreciate the suggestions and input as we look into developing our priorities for the next year. But it's included in our research plan to look at both short and long-term effects of pollutant.
Thank you so much for your answers, Dr. Sue and Bonnie. We did have a question that came through our Q&A. I also put it in the chat, but it said, can Dr. Sue talk more about the LUR model? What's the resolution of the derived criteria and toxic concentration pattern in California? Did the research team benchmark the derived spatial patterns with other information such as satellite observations or the AB 2588 air toxics hotspots emission inventory? Oh, Jason, I believe you're muted.
Yeah, for the criteria of pollutants and air toxics, we basically use the similar data source, but air toxics have more data source. For criteria of pollutants, so we basically have the impact of traffic, right? That's from Department of Transportation. You have 90 use, 9 cover. Those are all at a 30-meter resolution. For the traffic, it's basically we sampled it to 30-meter resolution. So then those are the basic information. You also have the like remote sensing data. like the ozone monitoring instrument, and also the AOD, and also the NASA data. So those are the remote sensing observations. We incorporate as what we could get, or what's available to improve our prediction of the merger concentrations. We also have we call it fixed predictors, like the elevation, and the higher elevation might be easier to disperse the pollutants, and then that's part of the reason. And also the the distance to coast will have an impact, and distance to road, and also what we used previous before Michael Jared was under one is the corridors. So goods movement corridors, those are one very close to the highways, and the non-goods movement corridors, those are the ones a little bit away but have major traffic impact, and also the control areas, those are very far away from the major impacts of traffic. So those for the non-use regression model. For the air toxics, we have those predictors being incorporated. Some of them, if they do not have impact, then they won't be kept in the final model selection, because the non-use regression model is a DSA model, is basically a deletion substitution addition model. But we did include the emissions for CARB have emissions inventory. So we did emissions from the air toxics. Some those ones. I also used the remote sensing data. There was one publication. So some of the air toxics are associated with some of the band combinations or the ratios of the MSI. So the remote sensing centennial too. So we use those ones too.
I just wanted to mention too that all these models are fit with what's known as V-fold cross-validation. So you're always fitting, 90% of the data, holding 10% out, seeing how well your fitted model can predict the data that's not used in that equation, and then repeating that many thousands of times. So there is a form of cross-validation that's built into the model through that leave out 10% algorithm.
Yeah, thank you, Mike. Yeah. So those samples are taken out. They're not in the model prediction, but only used in validation. So you might go 10 times or repeat it that way.
Okay, so I think that was our last question for today. So I know we're a little bit over time, so I'd like to thank everybody for making time to come to this research seminar today. Very interesting presentation, and very happy to do work with Dr. Su's team. Thank you all for your hard work. And if you have any questions or comments about this presentation that we couldn't get to today, please email them to the healthimpacts@arb.ca.gov, also in the chat here. And I hope everybody has a good rest of their Friday. Thank you.